So welcome back, everyone. It's still morning in Seattle. And we thank the last group of panelists once again, and it is my pleasure now to introduce Sophia Aragon, who is the CEO of the Washington State Center on Nursing, and I understand running for City Council, right, Sophia? A nurse running for City Council.
And thank you so much, Sue, for that introduction. And I'm honored today to welcome the panelists to discuss technology and how it informs practice and advancing equity. Okay, so first we'll have Sheila Shapiro, who is the Senior Vice President of National Strategic Partnerships with the UnitedHealthcare Clinical Services. Then we will hear from Eli Kern. He's an epidemiologist at Public Health Seattle and King County. And finally, Stefan J. Torres, a registered nurse from Swedish Medical Center, and he will also discuss the topic. Okay, so Sheila, I'll turn it over to you.
Hello, everyone. I would really like to, on behalf of UnitedHealthcare, thank everyone here today. Thank you, Dr. Hassmiller and the Robert Wood Johnson Foundation, and certainly the National Academy of Medicine for this opportunity. I'm honored and truly humbled to speak to you today on behalf of what UnitedHealthcare is doing in the realm of building and leveraging technology and infrastructure to support the healthcare system and the critical role that nurses play in the overall health of our nation. You may ask, why would UnitedHealthcare believe social determinants of health is important? As a healthcare company, we believe that everyone should have access to the needed medical, behavioral, and social services that our underserved and underinsured populations deserve. We also have many clinical professionals like yourselves who deal with barriers to care every day. When working with the people that we serve, and there are over 46 million of them, those 23,000 nurses serving in over 120 different roles all became nurses because they wanted to help people live healthier lives. And that is our united mission. While assisting members with their healthcare needs is critical, focusing solely on these needs can create frustration and burnout, as we've heard from the earlier panelists. I have an example where I spoke with nurses from across the country who are our clinical nurses in UnitedHealthcare, and I asked them in plan of care development, what was the #1 thing that they dealt with? And the issue that we may label patients as non-compliant because they're not doing what we're asking them to do was really tied to transportation. When we think about that implication on the work that everyone is trying to do to improve lives, we have to think about a solution in a different way. This work also goes very unnoticed because those same nurses that I spoke with did everything that they could, knowing what they knew, to address that transportation barrier, some with more success than others. And when they were unable to assist, the frustration and angst around not being able to help those people that they're charged to serve grows. In my words, the data has no voice, and the work effort is very difficult to quantify. So for the nurses and clinicians, we began to focus on health, not just health insurance. We have an ambition to redefine access to care. It is a multifaceted approach. We started with a hypothesis, and that hypothesis was that we could build an infrastructure around social determinants of health, something that could be used across the industry. Looking to redefine whole person care, to remove those barriers to care, and really look at the effectiveness of those outcomes, which we heard our panelists speak of in the last session. We're doing this in a multifaceted way. One, by making business investments in housing, food, and transportation. Two, through our clinical nurses in our house calls visits who are caring for people who aren't able to get to the physician's office. And to date, that incorporates over 5 million home visits. And many of those are due to lack of transportation or ability to actually get to the physician's office. We also are looking at industry change. We are going to be talking about the adoption of ICD-10 codes and the expansion of those codes to incorporate social determinants of health. And UnitedHealthcare is doing our part to ease the burden of making those referrals in a highly stressed system. We appreciate the work that the Robert Wood Johnson Foundation does in providing us research and basis to gain, I think, everyone's interest in a topic. And these stats are highly quoted now around the fact that 80% of someone's health really occurs outside of the healthcare system and now is known as social determinants of health. While that is a known piece of information, we do not know that at the individual level, and we need to think about personalization and individual response to social issues, not population-specific responses in and of itself. We're all individuals working through life, and those situations are individual and they change. States are trying to respond to the issues by really requiring managed care plans to not only screen for social barriers to care, but to also make those referrals. That is a critical change in the system, and that study that was done showed 19 states. It's up over 27 states now for Medicaid. Last year, CMS actually broadened the definition of supplemental benefits to allow health plans to actually think about benefits outside of the traditional constrained approach of only healthcare benefits. And as we think about preparedness of our healthcare system, while 85% of physicians in this particular study said that they knew that social determinants of health actually had an impact, only 20% of them felt like they really had the tools or the ability to address those issues. I've worked over 30 years in health insurance, and I've personally seen how socioeconomic factors played a role in my own parents' later years. There is a gap between health care and health, and I think we're starting to recognize that. I thought, why can't I help change the way the system thinks regarding so much of what happens to the people that we're trying to serve? So 4 years ago, I began the Strategic Community Partnership Program at UnitedHealthcare. The model that I'm going to share with you today has gained national recognition. The Healthcare Innovation Organization, formerly known as Healthcare Informatics, just this year awarded UnitedHealthcare the first ever insurance company innovation award for technology in this arena. While that is an important component, what they said, and I quote, United is unlocking the potential in truly harnessing social determinant of health data to support care management and population health management, unquote. And let me show you how it works. While technology is important, this is driven by people. And it's a very simplified, non-high-tech solution. We think about how social determinant of health data is collected. It's collected in various spots within the healthcare system, and we've heard some examples of that in the earlier panel discussion. Everyone collects it differently. Every piece of information around social barriers is actually stored differently today. The data has no voice. So what we began to use as our tenets is, first of all, we couldn't change the way people do work. We're thinking about this on a national level, and everyone does their jobs a little differently. Whether you're a nurse in private practice, whether you're a nurse in a clinic, whether you're dealing in a team with social workers, all of that work has to be taken into consideration. What we then did is looked at what coding was available in the system today, and we're leveraging ICD-10 codes. Why? Because we found evidence of physicians actually billing those codes that were available around social determinants. None of us were really paying attention. In that process, we knew that the data also had to have a value. So we have created a patent-pending imputed market price that allows us to place a value on every social referral made. That starts to give us the analytics to show clinical effectiveness and outcome, and it begins to set the stage for how we incorporate social determinants of health into our national health system. We recommended to the ICD-10 committee, based on our data, and the expansion of ICD-10 codes. Those codes were requested to be 23, based on the actual information that we had been collecting. We have support from the AMA, from NCQA, from the Arizona State Medicaid Office, and the National Association of Community Health Centers, and many, many others who have weighed in that having this common language to start to code social barriers to care or social determinants of health becomes critical. And we're awaiting the committee recommendation. But what is going on today is there are codes that are available and are being used. In February of last year, the ICD-10 CM cooperating parties approved the ability to allow others to document the social barrier codes based on information that was obtained by all clinicians. So expanding the team around which we all can work becomes critical. So my call to action to you is to look at that self-reported data, to document those social needs, and really to communicate this change in the system, because change is slow. What are we doing at UnitedHealthcare? We are actually doing our part to identify those individuals who need help, and we're actually making those referrals. Over 2.4 million people already have told us they have at least one social barrier to care. This is not a Medicaid issue. This is not a product-specific issue. This is a socioeconomic issue. And you can see that we have assisted over 500,000 people with over 700,000 referrals. And that closed loop process is now starting to become the next step in our work. We've generated over $250 million in social value to those individuals that we're trying to serve, those underinsured and uninsured individuals that need help every day. But we haven't done this alone. It has taken a village, and it will continue to take a new way of coordination and collaboration among organizations that haven't typically worked together. And these are just some of the organizations that have signed up to work with us. As I think about what we have as the future in front of us, I feel hopeful. I see change in the system. I know that we have the opportunity to work collectively in a different way with newly known information. We at UnitedHealthcare feel proud that we are a part of this new model of health, and I know that one person can make a difference. Thank you.
Thank you, Sheila. And next we'll hear from Eli. Turn.